Thank you to ImpediMed for the opportunity to speak this evening about the development and use of detection and monitoring thresholds with bioimpedance. In the literature, it's an area that there seems to be a bit of confusion, which can sometimes result in varied interpretations of bioimpedance findings, and that makes the literature seem more complicated. Tonight might feel like it's going to be a bit math heavy, but don't worry, it's really not that complicated, but it's critical to understand the assumptions that underpin the numbers that we use in screening and diagnosing lymphedema. And I'll try my hardest to make it very clear. We're going to look at how interlimb ratios are calculated, which is relevant for unilateral lymphedema of the upper and lower limb, as well as how we use those interlimb ratios to determine the thresholds that are suggested for the detection of lymphedema. There's a number of ways those interlimb ratios are calculated and utilized, and we're going to go through those options. So briefly, following on from the presentation a few weeks ago, I just want to make sure we're all on the same page by defining bioimpedance. So first of all, bioimpedance is an assessment tool. The outcomes that come from it can be used in various ways to screen for or to detect lymphedema or to monitor a treatment response. While we're using one tool for all of these processes, how we interpret the output may differ, including what thresholds we apply will likely differ depending on the context we're using the bioimpedance measurements in, whether it's screening, detection, or monitoring treatment response. And we'll cover these different thresholds more later. But to set up our discussions for the rest of the presentation, I think it's good to have a quick reminder of what we're using bioimpedance to do in the assessment of lymphedema. For patients with or at risk for lymphedema, we're using bioimpedance to assess the volume or quantity of extracellular fluid in the region of interest. We do this by passing a harmless low-level current through the tissue between electrodes. The current can be passed through the tissue at a range of frequencies, but at lower frequencies, the current cannot enter the cellular walls and therefore passes through the extracellular space. The resistance or the impedance that the current faces as it travels through this extracellular fluid is inversely proportional to the amount of fluid that is there. So as the quantity of fluid goes up, the measured impedance goes down, and vice versa. The outcome measure from bioimpedance assessment is shortened to R0. So this short form of the impedance is the impedance at zero frequency. This is an estimate as it's impossible to actually measure the resistance when the current is at zero frequency. But as a BIS tool takes measurements at multiple frequencies, it allows an accurate determination of what this theoretical number would be. Each measurement undertaken with bioimpedance will result in an R0 output. So if you are measuring the arms, you will receive an R0 output for both arms, both the left and the right arm, measured in ohms. With the measurements now taken, we have the amount of impedance at zero frequency, or R0, for both arms. And we use this to calculate an interlimb ratio. Much of the time I will talk about and use the numbers from the research on arms, but the same protocols and process are in place for the legs. The first step that was undertaken in determining how to use bioimpedance measurements for the assessments of limbs with and at risk for lymphedema was to measure a sample of healthy participants, those with no known risks for lymphedema. From this normative interlimb ratios, normative interlimb ratios for both the dominant and non-dominant arm were calculated. But why did we need to use a ratio rather than just the raw impedance output for the limb? And why do we need one for both the dominant and non-dominant limbs? Well, first of all, if we look at the ratios, in the literature we see that some papers use the actual impedance value in ohms as a threshold for detection or to monitor changes in limb volume or size after surgery, or to monitor the outcomes from the treatment for lymphedema. However, the actual impedance of a limb can change as the amount of fluid in the limb changes, depending on things like the time of day, what activities have been undertaken, and hydration levels. And we've all experienced that with changes in the way that our hands potentially feel at the end of a day. However, all of these things equally affect both limbs. So using a ratio instead of the raw impedance output allows these factors to be accounted for. It means that you do not have to do the measurements at the same time of day, or account for a patient's hydration levels on each day, or limit their activity in the lead up to a bioimpedance measurement. Secondly, in populations without lymphedema around the world, in both males and females, it's been clear that there's a significant difference in the amount of fluid in the dominant limb compared to the non-dominant limb. Therefore, we need to calculate one ratio for the dominant arm and one for the non-dominant limb. The same numbers will not be accurate for both arms. Because the amount of fluid in the arm is inversely proportional to the impedance, which arm you are calculating the ratio for is divided into or goes on the bottom of the equation. Don't worry, we'll go through this with numbers in just a second. So if we take the R0s from the original Cornish and team paper, which are the ones that are most usually used for the detection thresholds, they found in a sample of 60 healthy women without known lymphedema or risk for it, that the dominant arm had an impedance of 289 ohms. While the non-dominant arm had a higher impedance at 299 ohms. Therefore, if the dominant arm is the one of interest, you divide the impedance of the non-dominant arm into the dominant arm, resulting in a mean or average normative ratio between the arms of 1.034. If the arms had the same amount of extracellular fluid, we'd expect to see an interlimb ratio of 1.0. Reversing the numbers allows us to calculate the mean normative ratio of if the non-dominant arm is the one at risk. And here we can see the ratio of 0.986. So this means that, as we've said before, the dominant arm has more fluid than the non-dominant arm. This makes sense as we know from studies looking at circumference and volume measurements that the dominant arm tends to be bigger, which would mean more fluid. This is not uniformly the case though, for either circumference or impedance. There is variability in any population for most measurements. This is why we have a mean, which is 1.034, for example. This is a mean average, or mean or an average ratio between two arms for the group, as well as the standard deviation, which is the 0.034 after the plus minus sign. The standard deviation tells us about the difference between the mean and the other measurements of the group that were collected. This will become important when we consider our detection thresholds. So how do we go from having an average interlimb ratio, which we now know, to having a detection threshold that's actually based on this interlimb ratio? Well, the original Cornish and team paper suggested that a threshold at 3 standard deviations above the mean of a normative population should be used for detecting swelling. They said that you should use a normative or unaffected population to determine this threshold. They also said that you had to be a patient had to be above this threshold on at least 2 occasions to be considered positive for lymphedema. But why was a 3 standard deviation above the mean chosen to be the original threshold? The paper just said that it could be deemed predictive of the onset of lymphedema. Others have suggested that this is a very conservative threshold, so that if you saw a number above this value, you could feel quite confident that it was unlikely to be a normal interlimb ratio and therefore suggestive of swelling occurring. But why would you feel confident in saying that? We actually have to go back to our basic stats to understand this. When you collect data, one of the first things that you look at is to see if your data is normally distributed or if it follows the type of curve presented here, with most results falling around the mean. So we would expect to see most of our results falling within this center section, with the line here being the mean and the higher number of results falling in there, meaning that more people fall into that area. And whether it's height, shoe size, or limb impedance, we tend to see, or we look to see, that the majority of the results are collecting in the center. And that means that we have less and less people that are having measurements out further away from the mean. So most people will be a certain height, with less people being taller than that height and less people being shorter than that height. So 68% of scores will fall within 1 standard deviation of the mean or average. So 68% of the measurements we take, we expect to fall or should fall within 1 standard deviation. 97% will fall, or sorry, 95% will fall within 2 standard deviations of the mean, and over 99% will fall within 3 standard deviations of the mean. So by setting the detection threshold at 3 standard deviations above the mean of a normative population, we know that this score would not be considered or not be expected for more than 99% of the population. So it's not impossible to have that score without having underlying edema, but it's certainly not common. So while the original Cornish article used a threshold of 3 standard deviations above mean of a population, this threshold could be calculated for any distance from the mean. 1 standard deviation would incorporate 84% of all of the normative measurements because it would be only only measurements that above here would be considered normal for them, but abnormal for all of these, all of the rest of the population. 2 standard deviations, which would incorporate more than 97% of the population, and 3 standard deviations, which, as I've said before, means that the vast majority of measurements would be normally below that threshold. And from the Cornish paper, we can easily calculate what these thresholds would look like at the various points, as we know the mean and standard deviation. Notice the difference in the thresholds between the dominant and non-dominant arm. This is why it's important to accurately note whether the at-risk arm is the dominant or non-dominant side. Different thresholds apply depending on which arm is at risk. While many researchers may be familiar with the interarm ratios, they're not commonly used in clinical practice, nor in many of the papers examining the use of bioimpedance for prevention, screening, or detection of lymphedema. The L-Dex is the number that many of us and our patients would be more familiar with. For many, an interarm ratio is not easy or intuitive to interpret. It's much harder for a patient to picture whether you're improving or worsening when you're trying to remember if your last bioimpedance assessment reading is a ratio of 1.128 or 1.182, or something that appears to be subtly different but actually represents a significant difference in the amount of fluid that it's saying is there. The L-Dex score therefore takes an interarm ratio and anchors it to a more user-friendly scale, with the mean being a 0 and the mean plus a 3 standard deviation that we just looked at is a simple score of 10. The L-Dex scale still accounts for limb dominance. An L-Dex of 10 for the dominant arm, dominant affected arm is different than an L-Dex of 10 for a non-dominant affected arm. So our new normal distribution now looks like this. 10 is still our 3 standard deviation threshold. It is still rare, but not impossible to see an L-Dex of 10 greater than 10 in a patient who does not have lymphedema. That could be their normal for a very small percentage of people. So how might this look in a patient? If a patient undergoes a bioimpedance assessment before surgery for breast cancer, they could have, say, a resulting L-Dex of 5. At a later date after surgery and chemotherapy, they have another bioimpedance assessment, whether it's part of a screening program or a patient-initiated assessment due to the way the limb feels. They now have an L-Dex of 10, which, being at the 3 standard deviation threshold, would trigger some sort of management for edema. Note that with an L-Dex of 10, this patient has shifted from their baseline to a post-op measure of 5 L-Dex units. However, absolute thresholds like an L-Dex of 10 may not capture everyone who has significant changes in their extracellular fluid volume. For this patient, their pre-surgery L-Dex was -3, a perfectly normal interlimb ratio that puts them about 1 standard deviation below the normal average. When they are assessed at a later date after treatment has occurred, they now have an L-Dex of 7, putting them still significantly below the 10 L-Dex threshold. The shift in L-Dex, though, is large at 10 points. Patients like this are the primary reason for including pre-surgical measurements wherever possible. By definition, 50% of patients will have a pre-surgery L-Dex of less than 0. To get over 10, therefore, is a shift of more than 3 standard deviations, representing a significant increase in the amount of fluid in the limb. And in fact, in the original 2001 paper, it was recommended that a change of 0.1 or 3 standard deviations of an individual interlimb ratio, which also equates to an L-Dex change of 10 units, could also be considered indicative for developing lymphedema. And indeed, a number of papers have looked at the difference between using an absolute detection threshold versus a relative or change threshold of 10 L-Dex units, and found, unsurprisingly, that they detect different individuals of having swelling. So some people who have an L-Dex over 10 will not have shifted by more than 10 units, as in my first example, while some people who have shifted by 10 will not have crossed the threshold, the absolute threshold of 10, as in the second example. When no baseline assessment is available, the only option is to use the absolute detection thresholds to say whether or not somebody appears to have increases in their extracellular fluid. However, when a baseline pre-intervention bioimpedance assessment is taken, the absolute number, the absolute L-Dex value, as well as the change, can be considered in light of the presentation for determining if swelling is likely present. Further, thresholds need to also be considered, including whether you're using one set at 3 standard deviations above the normative population, or what is becoming more commonly used at 2 standard deviations above a normative mean. So if we think back to our normal distribution, a 2 standard deviation threshold brings our absolute cutoff down to around 6.5 L-Dex units. This may capture a few more normal measurements as being abnormal, but still won't include the vast majority of normal measurements. The 10 threshold has been suggested to be too conservative, willing to miss out on positive cases at the risk of false positive cases. A more liberal, lower threshold of 2 standard deviation thresholds has been suggested to better balance this risk. But how do we assess that? One of the original papers to suggest using a 2 standard deviation threshold was done by Fu and team in 2013. And they found using sensitivity and specificity analysis that an L-Dex of 7.1 was the best threshold to discriminate breast cancer survivors with lymphedema from those who were at risk of lymphedema. They decided this by looking at the sensitivity and specificity of various thresholds when we're compared to who already had a diagnosis of lymphedema and who didn't. So their reference standard was a previous diagnosis of lymphedema. In 2016, a publication from my PhD also suggested that a 2 standard deviation threshold had better sensitivity than a 3 standard deviation threshold when compared with when used with those with mild to moderate lymphedema and no lymphedema as determined by lymphoscintigraphy. Sensitivity and specificity analysis are important in understanding any threshold. Which one is more important, sensitivity or specificity, depends on the point and the goal of the assessment. So a good way to remember whether a test is what a test with good sensitivity is best at is the expression SNOUT. So a test with good sensitivity helps us rule out a condition from being present. Therefore, when it comes to evaluating things like a screening test, we are okay with some false positives, as a positive result on a screening test is just an indicator that further assessment is necessary. It does not diagnose someone with a condition. What we want to do with a screening test is to minimize false negatives where opportunities to intervene are going to be missed. So a test with good sensitivity is good at ruling out a condition, and therefore a negative result on a good screening test with good sensitivity makes you feel confident that the individual at this time does not have the condition. A 2 standard deviation threshold, or around an L-Dex of 6.5 to 7, has higher sensitivity than the higher threshold of 10, suggesting its utility as a screening threshold or as a trigger for early intervention. As opposed to SNOUT for sensitivity, SPIN is the expression that can help us remember the point of a test that is highly specific. So a positive result on a test with strong specificity is a good bet that the condition is present. So a test with high specificity with a positive result means that you're likely to have the condition that you're assessing for. While a test for screening with good sensitivity is aiming to rule out the condition from being present, with a diagnostic process, we are looking to minimize false positives, where we say that the condition is present, but when it's not. In our 2016 study, the 3 standard deviation threshold had a slightly higher specificity than the 2 standard deviation threshold. Now, many papers and research projects have investigated the sensitivity and specificity of various approaches to using bioimpedance outcomes for the detection of lymphedema. And I've just chosen to highlight 2 here. There is a large body of literature on this. And some of the results are contradictory between those studies. So what's really critical to understand is the pitfalls of sensitivity and specificity analysis, so that when you're reading these papers, you can make your own decision on these findings. The most important thing to be aware of with specificity and sensitivity analysis is that it's completely dependent on what the reference standard is, or how the researchers have decided someone has the condition or not. So it's critical, as this is the standard that the other threshold or the other assessment process is being compared against. Different reference standards will lead to different people being determined as having lymphedema or not, which will change whether, for example, bioimpedance or a threshold using with bioimpedance or any other assessment tool appears to be accurate or not against it. One of the major struggles we have in lymphedema research is that we do not have a gold standard for present or not. Therefore, we substitutes need to decide for yourself if you agree with the decisions they have made for determining the gold or reference standard for who has lymphedema or not. If you don't agree with their decisions, the specificity and sensitivity findings of that paper may not be relevant. But what does this actually mean overall? What does the research say about what threshold should be used? One of the early benefits of bioimpedance has been the use of normatively determined thresholds. This allows us to take normal human variation into consideration. No threshold will be perfect. All of them are a balance between minimizing overall presentation. However, there is growing evidence to support the use of a lower 2 standard deviation threshold, particularly during screening programs for lymphedema to trigger early intervention management options. To diagnose someone with lymphedema, a higher threshold may be more appropriate, but we should consider the caveat from the original study that 2 elevated measurements are required before they are considered a positive case. Finally, baseline assessments of bioimpedance should be included wherever possible. This gives greater ability to detect what is abnormal for an individual, improving the ability to access treatment at the earliest possible point to avoid the establishment of lymphedema. Thank you again for the opportunity to present this evening.